On behalf of the team at the Forum for Healthcare Strategists, Jen, Judy, Debbie, Krista, and me, Daniel Nyman, as well as our partners at Jarrard, Phillips, Cate, and Hancock, and Barlow and McCarthy, welcome and thanks for fitting us into your busy schedules. We understand that you are all deep in the throes of COVID-19 communications, so this time is especially precious. Right now, we think the best thing we can do for you is to provide real-time information from your expert friends and colleagues across the country. We've turned to some of the best and brightest to talk about what they're seeing and hearing and experiencing, and to offer advice for communicating with physicians during COVID-19. The conversation will be led by Lauren McConville, partner at Jarrard, and will include Chris Barlow of Barlow McCarthy, Rose Glenn, Chief Communications and Marketing Officer, Michigan Medicine, Dr. Rick Forrest, Vice Dean of Clinical Affairs and President, The Ohio State University Physicians, and Beth Toll, Vice President for Marketing and Communications, St. Luke's Health System. As we look ahead, though, we are rescheduling the Healthcare Marketing and Physician Strategy Summit to August 17th to 19th at the Swiss Hotel in Chicago. We'll be sharing all the details soon, and of course, going forward, we will be watching and reassessing. If it does not seem best to proceed, we won't. Now I'll turn the program over to Lauren. Lauren?
Daniel, thank you. And thank you to the Forum for providing the space to have this conversation. For those of you that don't know us, we are Jarrard, Phillips, Cate, and Hancock, and my name is Lauren McConville. We are a strategic communications firm that solely focuses on healthcare providers. And our firm in the last month has supported over 50 health systems and health services companies communicate through this unprecedented time. These challenges have absolutely tested the leadership teams we get to work alongside. And with these teams, we've created communications around preparedness, huge operational changes and challenges, loss of life, loss of employment, celebration of clinician and staff dedication, and so much more. We've realized in these communications, the most vital audience in all of this has been our providers, specifically our physicians, who are providing care and so often guiding large care teams across the country. We realized in our work that we were watching three major themes emerge as we think strategically about what we need to equip our physicians to know during this crisis. And I'm so glad to be joined today by four experts who will weigh in on these topics. We've largely seen three major themes. The first and most pressing has been creating just a simple information pipeline for clinical information that's literally changing almost hourly. What are those updates on policies, on PPE, on cleaning procedures, information that's essential we get into our physicians' hands. Second has been navigating key operational changes, whether it's bringing telehealth online incredibly quickly, setting up remote screening facilities, or creating alternate care sites with unlikely partners. We know we've got very real information we need to get into the hands of our physicians. Lastly, and perhaps most important, is ensuring that our physicians and frankly all of our caregivers feel our support, our gratitude, and our advocacy for their safety and well-being during these challenging times. Today, you'll hear from four experts shedding light on how their systems are tackling these challenges. I've asked each of them to also provide an update on not only where they work, so you know a little bit about the perspective from which they speak, but also where they are in the COVID pandemic. As we know, some systems are still dealing with their first few cases, while others literally have hundreds on their hands. Joining me today, all longtime partners of our firm, Dr. Eric Forrest, Vice Dean of Clinical Affairs and President at The Ohio State University Physicians, Beth Toll, VP Communications and Marketing at St. Luke's Health System in Boise, Idaho, Rose Glenn, Chief Communications Officer at Michigan Medicine, and Chris Barlow, an expert in the independent and recruiting physician space. I'd like to turn now, and Dr. Forrest, I hope you'll kick us off and just share a little bit about what you're seeing in Columbus, Ohio today as you think about COVID.
Our current situation right now is we're about 2 to 3 weeks away from our surge. And I think the state's done a very good job of the social distancing. And our prediction is that our volume will not be as high as it was in the past. We were lucky that we had a little more time to prepare for this, but also unlucky in that you feel like there's this impending doom and you just don't know when it's going to hit. And I think that's impacting a lot of the morale of our physicians currently.
Thanks for that, Dr. Forrest. Beth, how about Idaho?
Hi, everybody. In Idaho, we saw our first case on March 13th. So we have not hit our surge peak yet. We are anticipating that. We're hovering right around the 1,100 to 1,200 confirmed cases currently. And, you know, we've been managing well. Our providers in this community have stepped up, leaned in, and one of the things that's been very exciting for us to see within our community, especially with the rural nature of our state, is the collaboration across facilities within our health system, but even more importantly, the cooperation of providers across facilities that in normal circumstances we may be seen as competitors, but the collaboration has just been incredible. So we're early in this process. We're preparing as best we can, and our providers have been just incredible partners in leaning in to help us be ready.
Beth, thank you. Rose, would love to hear what's happening in Michigan. Rose, you may be on mute still.
That's probably a little better.
There we go.
Hi, everyone. As you know, Detroit is considered one of the hot spots in the country, and Michigan saw its first case right around March 9th. And since that time, we had a number of significant surges. We expected potentially to peak this week. This week is supposed to be a particularly bad one. We are seeing many patients. We have inpatient right now, well over 200, but we have tested many more and seen many more in our ambulatory sites. It's you know, similar to Beth's comments. We are taking a lot of transfers in from Detroit hospitals. It's been a collaborative effort, and really that's been critical, I think, to support all of Southeast Michigan during this time.
Thank you, Rose. Participants, I'd like to let you know, if you hover your cursor in the bottom of your screen, a chat box will appear and you'll see a Q&A icon. As you have questions throughout the presentation, please feel free to share those with us and we will weave them into the conversation as we can. Dr. Forrest, I want to turn back to you first. You spoke a little bit about this feeling of doom. I know that's been a top of mind for so many of us in the communications field, is really understanding the morale and the mindset of the physicians at the bedside and really knowing what their top concerns are so we can hopefully help alleviate them where we can. Would you mind sharing with us your perspective on that?
Sure. What we're seeing is more of a bimodal distribution of the faculty here. And we have about 1,900 faculty between APPs and physicians providing that frontline care. And on one extreme, you've got the very anxious provider that wants to jump in and be active from the beginning. And then you have another group that basically is withdrawing and trying to avoid any type of contact at all. And so it's really managing the two extremes that make it a little bit challenging in that regard. The other thing that I think is really key in managing this situation is that everyone will look to leadership during this time to really set the tone. And I think as leaders, we need to be very calm and give them a sense that we have this under control, but you have to be honest about the communications and not overly optimistic and really confront the true facts that are present. You know, from a personal standpoint, I'm still clinically active and I was exposed to one of my nurses that was COVID positive, and I can empathize to our clinicians as to the stress that put under was for me. I didn't want to be around my family. You know, I really didn't want to go into quarantine more than I am currently. And it was a very stressful situation to not know what was going to happen. Thankfully, it was a low risk exposure. And, you know, I didn't have to do anything too aggressive, and then the time has passed and I'm no longer considered at risk. But I think that experience made me kind of understand some of what the faculty felt on what they needed to, or what they were going to go through. When you talk about the withdrawn side, it's really, you need to let them know that there is security for them and that we're doing everything we can to protect them. The opposite end, where they're very anxious and ready to dive in, we have to let them know that it's okay not to be busy right now. They're on deck, so to speak, and we are going to get healthcare providers leaving because they're either in quarantine or they get the coronavirus themselves, and we're going to need other people to step in. So they don't need to be available right from the beginning, but we are going to need them all at some point, and to take this time for some personal development and do things that prepare them for going into the surge, educational materials that we've provided to teach them how to be an inpatient doctor or work in the critical care unit. And those things are very important. And I think that is one of the things we did very early on, is just to reassure them that it's okay for you not to be busy, but here are some of the things you need to be doing this period of time to prepare yourself mentally and physically to step in when we need you. So that's kind of the approach that we have as far as the workforce is concerned right now.
Thank you, Rick. Those insights, especially the personal nature of them, are very helpful.
Yeah, one other thing that I should mention, that early on, so we have 4,500 cases in the state of Ohio. We've had 142 deaths. One of the first deaths in the entire central Ohio area was one of our long-term administrators. And it hit home so quickly and early on that it made everyone realize that we're going to feel this. We're going to have our coworkers, we're going to have people that work side by side with us that die from this disease. And I think that, again, galvanized our staff, both faculty from a physician standpoint and non-physician standpoint, to really want to be aggressive in managing the situation. And hopefully no one will have to experience that at your institutions, but when it's someone that you know very well and is very close to you, it makes it a lot different. And the messaging around how you manage that is really critical.
Yes, well, and Rick, you've keyed on two things we've seen over the past few weeks as well, which is that commitment among leadership teams to be calm and to be authentic and recognize that this is going to hit close to home in such a personal way. I'm curious, Dr. Forrest, I'd love to hear you respond first, and then Beth and Rose, please weigh in for what you're doing. How are you ensuring all of this information that they need to see is actually making its way to our physicians, knowing how busy they are, knowing the challenges that, frankly, on a good day, keep us from doing a good job in communicating with our physicians? How are you ensuring, Dr. Forrest, that they know what they need to know on available PPE and on key operational changes, let alone some of these messages of advocacy and support?
Yeah, that's really key, Lauren. I think it's very important on how the message reaches the people of the organization. You need to have more of a global message that is centralized, consistent, very clear and concise, one true source of truth, or one source of truth, if you will, that goes out on a daily basis to being global enterprise. And that is really key. And then on the more personal side, you have where you engage the chairs and some of the local leaders to provide that information to their staff, because on the personal level, they will have a better communication and relationship with the people under them. And it doesn't seem like it's all being pushed down from above. When you talk about that, you have to speak of multiple points of touch. So the daily communication is one level, and that's the global perspective, but you also need daily huddles at multiple levels of the organization within each of the business units to kind of see how they're doing on a daily basis. What are some of the things that need to get done that day? That's very important. Then there's targeted communication that goes outside of that one daily message that goes out to all the staff. Now these we tried to prioritize as being hey, this is really important. You need to listen to this. This isn't part of the daily update. And that has to do with where we stand with PPE. We just recently changed our masking policy and we wanted to get that out as a separate communication so everybody was up to date with that. It's compensation discussions to both our staff and the physician groups. It's about wellness, and it's also about how to engage the leaders that the faculty will look up to. We do a lot of Zoom meetings where we pull all the chairs together or our work groups together, and it's a lot about questions and answers and then follow up to those messaging. And I think that's really important, is to make sure there is a follow up to all the questions that come up. And then we even encourage at the department level to develop virtual support groups. The problem that you get in these situations and people who are working from home is the strong sense of isolation, and that intensifies the fear. And as everyone can attest to, dialogue is the core of the culture of any organization, and people need to be speaking to each other. And I think these group chats and the Zoom meetings are very helpful in doing that, because that just gives them a sense of community and belonging that they can't get right now because we're not seeing each other every day face to face. So those are some of the messaging and how we try to get it to the different levels within the organization. But I guess the thing I want to emphasize is it's as Lawrence mentioned earlier, it's being honest about the communication that's going out there, but also leading with truth and facts. We can't paint this rosy picture, and then when something happens, they're going to feel like the leadership let them down. We will all be criticized at some point during this journey, and the way we handle it now may not be evident until later on when the crisis is over and people feel like we were not supported well enough during this journey through the crisis, and then they start questioning the leadership that's out there.
Dr. Forrest, thank you. Love to hear the focus on multiple tactics. Rose, Beth, would love to hear how you're thinking about getting that information that's needed most to your physician partners.
I would just emphasize that Dr. Forrest's note about having a daily update has been really important to our communication at Michigan Medicine. We do a daily COVID update that is a number of brief but really important notices to our entire physician and employee population. One of the questions that has come up on the chat is, when do you hit email overload? And initially, when we first activated the command center, we were doing 2 of these a day. And we realized that was causing, I think, more stress than anything.
Yes.
And so we went down to 1 a day, and that has been the most valued instrument or tool that we've used, because we did a quick survey last week to ask people of the myriad of channels that we were using what was most appreciated. And that daily email was number 1, followed by our weekly town hall meetings that are videocast or streamed across our entire community, our Michigan Medicine community, and that's been extremely well received as well. But we're constantly monitoring for overload. The other thing that you brought up was, what kind of messages of advocacy and support. And those daily emails, although they have to summarize a lot of critical information people need to know, we're trying to more and more add messages of advocacy and support, whether that's support from our Depression Center or our Wellness Institute, different things that we have put together to support people during the pandemic, or just thank yous, gratitude. We've started a campaign called #Health to the Front Line, and showcasing some of the people who've posted in that. Those are all really, really appreciated by our team members.
Rose, thank you for that. Beth, any thoughts?
Yeah, thanks, Lauren. I'll just build on a couple of the comments already made and not repeat some of the examples that we're doing similar things. One thing I'd like to highlight for the group is early on we recognized that we were adopting the Hospital Incident Command System, or HICS, and we didn't want to assume that every one of our providers would understand how that might change their regular communication channels. And so we spent some time early on really clarifying and establishing how information was going to flow and how decisions would be made. And that was important because as these providers are on the front line, they obviously have a significant need for information. They want understanding and awareness of status of critical items such as PPE, et cetera. And we wanted to minimize the amount of spin or effort that they had to invest in identifying where they needed to go for that information. So once we established that information flow and decision-making structure for them, we really built our communication structure around that so that it complemented it. And we focused, both for our providers and for our staff, an approach that really was centered on value of communication over volume. So we worked together to identify what was the most critical information and what was the most appropriate cadence to distribute that, so that we were meeting the need of timeliness, but also not overwhelming our providers and other stakeholders with too much, because in the early days, there's a lot of spin around all of the need to know. And we invested time and effort to make sure we were doing our best to focus on the value of the communication and reduce the volume. The other thing that I'll mention is that we focused on creating that single source of truth that Dr. Forrest mentioned. Our infection prevention information hub really became the receptacle for everything. Everything was parked there, regardless of the audience. But then what we ended up doing is layering it through the other places where physicians might choose to access it. And one example would be the provider portal, so that we reduced the friction of them getting to the information, and we made sure it was available through their normal channels of access, so that it was easy and more intuitive, and we weren't adding another layer for them to figure out as they went through their day. One other point that I'll add for the group that we recognized a little way into our journey was, as information was changing, as guidance was changing, it was very difficult to ensure that everybody understood what the most current version of the recommendations or guidance was. And so we hardwired into our process, and it may seem like a simple thing, but it was important, a version control, date stamp, time stamp, so that we could reinforce the confidence of our providers who were accessing this guidance, that they were using the most current information in how they were practicing and caring for their patients and working together. So that was one lesson learned that I'd like to share with the group, is something that we maybe recognized that a little bit late. We implemented it, and it's something that you'd probably want to consider implementing early because it was very helpful.
Beth, I'd like to direct some of these questions coming through our chat box to you.
Great.
Seen a lot of questions around how are you getting information, what information are you sharing to community or independent physicians? I would love to hear what you all are doing at St. Luke's, and then Dr. Forrest, if you have any thoughts in Columbus.
Sure. For our independent physicians, and for context, we have both employed providers and independent providers that we work with. It's a nice mix of both. And any independent provider who has privileges here has a St. Luke's email. And so everything that we posted on our infection prevention portal is available to them by using that St. Luke's email address. So that was an important thing to clarify for those independent providers. We also made sure through our network that as we were communicating information, that we shared that information with our network providers too. They may have been getting additional information from other resources, which was important, but we didn't want to overlook the fact that some of our independent providers, and depending on the amount that they were practicing, they may not have access to all of that information, or would have had to invest a considerable amount of time in identifying it themselves. So we tried to focus on removing those barriers by including them as much as possible in everything that we were communicating.
So Beth, on that point, are you and your team taking the time to repackage, or are you simply sending under the header of, if this is helpful, this is what we're sharing with our employed physicians?
what we primarily do is we don't send a lot of content separately. We're using a lot of links to that IP information hub that I mentioned.
Okay.
So if there is an update, we link it directly so that, again, they're seeing it as an update, but then they can click in and get into that portal and access the information, whether it's a new policy, maybe it's some new practice guidelines, maybe it's an update to a process or direction we had provided, the week before. So we're really relying on that one source of truth to house the deep content and notifying our providers that there's been a change or an update, an addition, by sending them the link to that information.
Thank you. Dr. Forrest, any thoughts on how we keep our independent physicians importantly in the loop?
Sure. One of the things a statement that I use a lot around here, even before the crisis, is be a purpose maximizer, not a profit maximizer. And we always have to do what's right for the people we're taking care of and our own people. And it's not about how much money you can make. And with that spin on it, the way we looked at this isn't a time to grab market share or optimize what you can charge for services. This is about everybody working together to serve the community in the way that we can, and to minimize any impact and loss of lives in this area. So we've reached out to the other 2 health systems here in town. I've reached out to their physician leads directly, and we share everything. What are you doing to keep your staff whole from a compensation standpoint? What are you doing on the physician side? Because we wanted to make sure that all 3 systems were doing something in a very similar fashion so that nobody was singled out in that regard. And I know that's not independent physicians, but that's what we've done across the 3 health systems here. There are a number of independent physicians in the city, and we've reached out to some of the larger groups to share what we would consider best practices, things that we're doing currently, see where we can help them with testing and so forth. We have done the majority of all the testing in the entire state at Ohio State, and whatever we can do to help them. We've shared policy changes with them. Here's what we're doing. Here's what we're doing as far as masking. Here's how we're trying to protect our staff. One of the other things we did very early on, being an academic medical center, we worked with Battelle, which is a research institute here in town, to develop a way to sterilize and reuse the N95 mask through a hydrogen peroxide misting technique, which allows you to use them up to 20 times before having to discard them. And we very quickly looped in the other 2 systems to say, hey, start using this so you can protect your PPE and get this equipment to keep it in the hands of your physicians. And now this technique is now being pushed out on a more national level to other areas that are experiencing the surge. So it's a great way to improve the PPE that you do have on hand to be able to do that. And I think the message here is, this isn't about any individual physician. This isn't about any system. This is about us all getting together and doing the right thing. And I think that is the big message here. I think one thing we'll realize from this is our worlds will never be the same after this. The way we deliver care in the future will always be permanently changed by this. And I think it's a great opportunity for the healthcare industry to really step forward. I think the public opinion of healthcare in this country was somewhat jaded going into this because of the cost involved. I don't think anyone really questioned the quality, but the overall cost. But then when they see what we're doing on a national level to step up and take care of everybody, there's a different sense of gratitude, I think, for the industry that wasn't there prior to the COVID crisis. And I think it's up to us to follow through and make sure that we minimize the impact of the health of the people that we serve across the country. And that's about all I have to say, Lauren.
Thanks, Dr. Forrest. Rose, wanted to come back with you. There's been a lot of interest in the survey you mentioned. Would you mind sharing a little bit more about that? Were you asking specifically about channel preference, frequency, the messaging that physicians would value? Would you mind sharing a little bit more detail?
Sure. We wanted to make it as brief as possible because we knew how busy people are. So we asked first and foremost whether the information they were getting was of value to them, was meaningful. We did a scale of strongly agree to strongly disagree, with 1 being disagree, 4 being strongly agree. We averaged 3.2 on the meaningful question. We then gave them a list of things that we did and asked them to check which ones they were either opening, tuning into, etc. And that was where we learned that the number 1 tool was the daily email. The number 2 was the town halls.
Okay.
And so it was basically a 3-question. We also asked who they were. So were they a physician? Were they a nurse? Were they another person on the clinical team? We had about 7% of those who responded were physicians. So it was small, but we still thought relevant. We had about 50% overall were from the clinical team members, which we really wanted to hear from. We received a lot of written feedback because we did have 1 box for what else could we do to improve. Okay. And we're now bucketing that feedback into different priority areas and trying to learn from it as we go.
Thank you, Rose. I'm seeing a lot of questions come through about physician liaisons and how do we stay connected to our referrers. Chris, I'm going to turn to you. We're lucky enough to have Chris Barlow on the line with us. She's an expert here in referring physician strategies. Chris, would you share some of the thinking with your group, and then we'll go back to questions from the participants?
You bet. Yes, thanks, Lauren. And hey, great insights and perspectives, right? I wanted to share some of what we're hearing from organizations and to spend a couple of minutes on that physician audience that is outside this inner circle in this crisis. And I'm going to get a little more tactical with some of this. So for me, it always starts with a segmentation plan. So I feel confident I've got everybody covered, right? It's the right physician communication with the right message to the right audience at the right time, which is what your experts have just talked about. Now more than ever, I think relevance really matters. So I want to talk about that segment that's not in the immediate circle for hospital-based diagnosis or care delivery. For many of you, it's part of your CIN or independent primary care or those independent specialist groups. Most organizations have really strong physician relations or liaison functions. If you have not deployed them to actively connect with your physician audience, boy, I'd encourage you to leverage them to get the message out to the greater physician audience. They can do it in a customized way, and they can do it in 2-way communication. The other interesting thing is they all have target lists. It includes this audience, and most of the time they already bring to it a really strong working relationship with those doctors. The immediate thought is that these doctors are way too busy to take a call or to read an email. It's just not the case. Liaisons all over the country are sharing that this personal connection, it's just like Dr. Forrest talked about. It's a wonderful difference maker to have somebody reach out and say, how you doing? So one of the other things that we're hearing from liaisons about this audience that I think bears consideration as you organize your communication is that there's a whole lot of patients who are using a cardiologist or an OBGYN or perhaps their endocrinologist as their primary care. So it's a different group of offices that are getting a whole lot of primary care type questions, and I don't know that we anticipated that. The other challenge that we're seeing is that specialists saw their business disappear overnight when organizations shut off electives. They need perhaps less messages that are pure COVID-19, but they certainly want to keep involved and in the know. It's what Beth talked about, making those emails available to them so that they can glean what feels important. Again, a lot of their messages need to be on different topics. So what we're hearing in these outreach conversations, and they're happening by phone, they're happening by email, they're happening by text, they're still happening by fax for a whole lot of teams, but it's topics related to knowledge and resources. it's absolutely amazing how many physicians say, I don't know who's a point of contact in your hospital. You know, a year ago, they didn't really need to care about who's involved and can be a helper in there. That's gone now. And then that category of how are you that our panel has so aptly mentioned. I want to just say that a liaison team doesn't really need customized messages. As you've all described, they need that message vault to stay relevant. Consumers can provide that, and I love, Beth, the date and time stamp that you talked about, to provide them with some tools that they can push out or that they can customize if their audience has interest. So the push-pull of this, and Rose just alluded to this with the survey piece, this communication that we're looking at has to be a two-way process. A lot of this is about where all of you are from a communications vantage point with that right spokesperson to make sure we give the right messages. But I want to take just a minute to encourage this feedback loop with our doctors. It's real-time feedback from our doctors, and it really matters. My chart, the 4 categories, will likely resonate more with the primary care audience. I provided some ideas of topics that we should be asking 1 to 3 questions. You can send it out in an email survey. You can have the liaisons absolutely ask these questions. They can do it in a segmented way to be able to say, with our employed primary care docs, where are we with this? How does that vary if we're talking about some of these independents? That opportunity for us to look at those 1 to 3 questions and call that information, bring it back to the command center, and really allow that opportunity to hear that voice of this customer group moving forward. I think the crisis is alive in many of your markets, and we're sure hearing that. But, you know, as Dr. Forrest described, some of us are more on this anxious preparation phase. So as we can ask about their needs and their perceptions and their readiness, it's a really good insight. Clinicians at every level absolutely want to be at their best. So why don't we ask them what they need so we can help them be there?
Chris, I'm sorry. I just wanted to give you a real life example of that. This is Rose, and Josie Aguirre, who leads Michigan Medicine's Physician Liaison Program. Her team contacted over 700 independent offices in 2 weeks to make a personal connection, answer questions, and direct them to our COVID-19 website. And it was extremely well received and appreciated. So I just wanted to give you a real life example.
Absolutely right, Rose. And that just that outreach on behalf of your organization to say, where are you with it? And again, I think 1 to 3 questions in the SurveyMonkey tool that can go back to leadership as a regular pulse check, because we all got started with this. But as time goes on, I think we need to go back and reinvest in this. So I've got one closing thought for you on this. On the next slide then. I think we're all looking forward to that day when all this is in a rearview mirror. And every organization is pretty anxious for those elective surgeries to come back to our organizations. I think to your point, Rose, with how Josie did this and all of us, how we manage our responsiveness now is certainly going to be remembered. So Lauren, back to you and more questions.
Chris, thank you. And questions are pouring in, so we will go there. Really, Rose, Beth, Dr. Forrest, would love to hear your perspective on this one. You've all mentioned how important it is for leaders to remain calm for staff. The question is two-pronged. First, how do you keep healthcare workers calm? And then secondly, do you see they seem okay on site, but then turn to a place of concern, confusion, or angst outside our hospital, like on our social media channels? Thoughts on how we control or direct energy there? So how do we keep folks calm inside our own doors, and then how do we think about their well-being when they leave?
Lauren, this is Beth. I can answer part of that question related to social media if you'd like.
Please.
We have seen our providers as excuse me, as well as our staff members really share their perspective via social media. Some have written opinion pieces for our local newspapers. And what we've tried to do is, on one hand, reinforce our internal processes around those topics, right? The policy discussion and all of that. But more importantly, we have reached out and offered support from the communications team, if that's desired, not to control the message, but to help them really articulate what they're trying to share. And that has been pretty successful, because if you can acknowledge for these individuals that they really do have either a commitment to sharing information or they have something that they passionately believe, you want to be able to help them share that effectively. And so that's been appreciated. On the provider side, we've also had some success in peer-to-peer conversations in reinforcing what I think some of our providers forget sometimes, and that is helping them understand the weight of their words, helping them understand that medical credential, the position that they hold in the community, especially in some of our smaller communities where providers really are seen as community leaders. Having some peer-to-peer discussions when they have something that they want to share, to be able to reinforce the weight of their words and to be mindful about how they share or reflect information. That's also been really successful for us. So our aim has not been to tell people not to try and minimize their opportunity to express themselves, but to really help them shape their message so that it hits the objective that we believe is behind most of what they want to express, and that is to help or to help influence changes in behavior from the public, whether that be a stay-at-home order, hand washing, stay home if you're sick, and some of those other key messages. So that's the approach we've chosen to take in facilitating our folks expressing the real emotions that they're feeling as they navigate this challenging time.
Beth, so well said. Thank you. Dr. Forrest Rose, anything different there?
Yeah, I agree with Beth. I think it's a great approach that she has. You know, it's really, I hate to use cliche terms, but the shadow of the leader is really important here, and getting out and not secluding yourself, going to the hospital, talking to people, and having that calm and reassuring voice and message is really important. I think we have to avoid any type of mixed messages that are getting out there, and a lack of communication. That void will be filled by people creating stories within that to create uncertainty and anxiety, which is what we need to avoid. A lot of it is peer-to-peer conversations. When we hear about physicians saying things on the floor in the clinics, just pulling them aside and saying, hey, look, you know, people are looking to you as the leader of your unit to kind of set the tone here. And if you're in a more of a panic mode, all your staff are going to follow your cue and be in a similar mode. And that's really some of the messaging that we've been trying to do, and really focus on, you know, giving people a voice. You know, your frontline staff have to be able to express the way they feel, and those concerns need to be elevated up to the leadership level so that we can work on addressing them. Whether it's, I don't like a policy regarding masking of all of our staff. That was the one we heard early on, because we stated you didn't need to mask everybody. Now we've changed that. And so when you hear these concerns of what people are worried about and then addressing them as quickly as possible, that is an important way to keep people calm. But it's also in the way you deliver the message. And I think that is very important for people to read it and not read a message and come out of that feeling like they're in panic mode because of the message you provided to them. So that's all I've got to say, Lauren.
Thank you. I've seen a lot of questions for specifics around gratitude. Specifically, how are you supporting your clinical team? You've seen some things in the chat box here, you know, yard signs with the message, heroes work here. I would love to hear things you're doing specifically at your system, or frankly, that you're watching your community or your foundations do to support your system that you think are really having an impact with your providers.
At Michigan Medicine, we've had an outpouring from the community. Yard signs, food donations, a lot of food donations that we have a couple of people just coordinating that and making sure that it gets out to the frontline staff. The hashtag campaign I mentioned earlier, we're now going to take that to a second phase and do video clips of our employees talking about what it's like and thanking their coworkers. We also have we also have an internal Facebook page that we're utilizing to do a lot of our thanks to one another and to our staff. So I don't think you can find enough ways to express that gratitude, but I'm going to go back to the personal thank yous that we provide during the town hall. Prior to this pandemic, we didn't live stream our leadership giving sort of a state of the organization address and expressing gratitude. And people are so appreciative of this town hall and the authenticity and the empathy, because it's so much easier to express it verbally. And then they also appreciate that two-way engagement and being able to ask questions in real time. And I think that two-way it's been mentioned a couple of times, but I don't think during times of crisis it can be emphasized enough. The FAQs that we post on our main internal pages for our COVID-19 discussions, the FAQs, the general ones, have been clicked on 26,000 times. The HR specific FAQs have been clicked on 35,000 times. And so people are going to them daily, and still we find that we have to emphasize that they're there for, those questions are there, and they're a great resource. So what we're finding is that we have to continually listen and develop responses and get those responses as widespread as possible on different channels, so that people feel the information is coming. And part of that is expressions of gratitude as well.
Got it.
I have one small one that I just wanted to add and build on the last two comments that I discovered yesterday that surprised me. I was on hold with our information technology group, as employees often are as they're waiting for support. And one of the things that I loved was a recorded message. You know how the cycle messages go through as you're waiting. And it was our IH team members expressing in a very sweet way their gratitude for the caregivers on the front line. So it was a peer-to-peer recognition, and it was so genuine and surprising. And again, I wasn't expecting it. So there's examples like that too, where peers are taking it upon themselves just to express in unexpected ways what they feel. And some of those organic options and opportunities are just pretty awesome to maximize.
Beth, building on that, I'm seeing some comments in the Q&A box. Others are saying they've had local florists deliver 1,500 orchids that, were going to go bad since a lot of folks aren't buying flowers right now. And they've put these around hospitals and nurses' stations to show gratitude. Love to see that outpouring from our community. We had some follow-up, Dr. Forrest, Rose, Beth, after the great comments on how we shape messages from our staff and our providers. Let's take it one step farther. How are you all working with physicians or with employees when they have messages that go against hospital policy? So if you've got folks sharing strong opinions about PPE use that differ from your organization, when those messages go a bit off track, I think we've got a lot of folks on the line who would welcome your thoughts on that.
Yeah,
go ahead.
No, please go ahead.
No, I was just going to say that, what we try to, this is again, that clear and concise information that is provided. And when we hear people doing things that go in against the policy, we try to figure out why they're doing it and speak to the leader of that area directly. We had one of our departments kind of go against everything that we were trying to do from a policy perspective. And if we would have done what they suggested, we would run out of PPE very quickly. And then it just comes down to explaining the why. Why is this policy the way it is? Here are the facts around it. Here's how we got those facts, and here's based on experiences in other areas. So New York is ahead of us, and we used examples from there, in China, and we spoke directly to people in those areas to see what worked and what didn't work for them. And then we explain that to our staff and say, here's the truth as we know it today. If the information changes, then we will change our policies to reflect the best ways we can protect you. But you have to understand, by overusing PPE now, if we do get into a crisis situation, you are creating a different issue later on by overusing that equipment now during a phase where we don't really need to be doing that. And that's the kind of approach that we have done. It's really important to listen to them and figure out why they feel that they need to go against the policy. And then we need to explain to them why it's in their best interest to do this, and that there is a rationale behind why this policy was written, and we're doing it based on facts, and that's the best we can do at this time. I mean, this is unprecedented what we're going through. Nobody has all the answers, and we tell them that, but to the best of our knowledge, this is what's working for us now.
Yes. Beth, anything else there?
Well, that was really well said. I think the only thing I would add to that is that it speaks to the critical nature of having your feedback loops really hardwired, so that you can express to the team how they escalate their concerns, and then being responsive to the best of your ability in a very timely way. It doesn't remove all of the risk of what we're talking about, but what it does do is it takes off some of the pressure where providers, employees feel that they have a path to get their concern addressed.
Yes.
And hardwiring those into the process early on has been something that has, I think, helped us minimize the number of times we have to follow up with other sorts of actions.
That's exactly what we've been recommending with client partners this week as well, is to make it as one-on-one as we can, so we avoid some of the horror stories we've seen in the media.
I will add to that, though, because I think Michigan Medicine it is doing many of the things that were just stressed as really good best practices. But for all of those out there who are still struggling with very concerned nurses and other staff, it's a very, very real thing, the anxiety, the fear, the stress. So even though we talk about the science of why we don't want people to bring in PPE from home, it's not just a scientific issue, it's a strongly emotional issue. Yes. And our nurses, we have a nurse union, and our nurses are articulating very strongly that they want the PPE from their homes to be used at the work site. So now we're going to schedule a meeting between the union leadership and others to talk about, why we have the policy we have, where it's endorsed, but at the same time showing a lot of empathy, because it is just really scary for those on the front lines, and we're trying to walk that line between having really great policies based on science and being empathetic and understanding the fears.
Well said, Rose.
Yes. Beth, specific question for you.
One thing, Lauren, I just want one quick comment.
Rick, yeah.
When we're struggling with allowing people to bring in their own personal PPE as well, and what we're experiencing in some situations, especially in the ambulatory setting, is people using N95 masks where it's not indicated, where you have say a nurse going into a room and everyone else there, the MAs, the physicians, going, well, why do they have it and I don't? And not everybody has their own personal PPE. And once you set that precedent that someone needs to have an N95, or you're allowing them to have an N95, everyone else in that clinic will want the same equipment. whether they have it or not, and that can become an issue as well.
Yeah, I can only imagine the challenges and stress that is putting on folks in your position, Dr. Forrest. Thank you for sharing those thoughts. Beth, we had a specific question for you. A lot of interest in the portal you described earlier. Would you mind clarifying, is that something through your EMR or is that a standalone comms portal?
It's through our intranet. So it's a standalone comms portal.
Okay.
And it's interesting because our infection prevention team has always had a page, never been so popular. And so they're feeling like rock stars. No, but that's ultimately where we parked it. And we've got it segmented by audience. And what I mean by that is it's not segmented in a way that you can't access the different components, but we tried to prioritize and make it clear what might lean more toward provider interest,
Okay.
what might lean more toward general interest, where might we find HR related, staffing related items, et cetera. And we've organized it all in one spot. And as I mentioned, then we layer it through other connection points. So we're not repeating the information, but driving everybody to that one location makes it much easier to maintain, much easier to keep updated and current. And it keeps that consistency and clarity that we're trying to drive through for our communication.
Last question. Seeing a lot of comments, Rose and Dr. Forrest, you both talked about using Zoom. Chris, this question's directed to you. Are you aware of our physician liaisons who are successfully using Zoom to establish provider-to-provider connections now that many areas are under shelter-in-place orders?
Yeah, so virtual meetings are alive and well. We're at this place where while all of the emphasis is on COVID-19, people are still getting diagnosed with cancer or heart disease or those sorts of things. Lots of times it's happening if specialists need to talk to primary cares. They can use a Zoom or a different virtual tool. The other thing that's really interesting is for physicians who are new and joining medical communities, think of that audience during all of this, right? You're brand new in practice. So there's been some interesting use of Zoom and virtual meetings for some onboarding. So, creative ways to use tools like we're using today. So, yeah, it's worked pretty well. And again, that segment of the population that's physician population that's outside the immediate crisis or in the wait and see, there's excellent opportunities to do some good connectivity if we take advantage of the virtual tools.
Thank you, Chris. Really, I just wanted to thank first our panelists for dedicating their time. You can hear how busy their daily lives are, as I know it is for many of you on the call. Dr. Forrest, Beth, Rose, Chris, thank you for your time and your counsel. And for those that attended today, over 600 folks, which is hard to believe, we will follow up with questions offline. So those of you that submitted questions we didn't have time to discuss, we will be circling back with you as well as providing these few slides in case they're helpful. Thank you to the forum for continuing to provide the space for these important conversations. And I'm hoping we'll be able to announce soon the next few topics and dates you all can count on these for. Thank you, and I hope you all stay healthy and well.